Good afternoon. I'm Dr. Felice Resnick. I am the lead research scientist for the Dissemination and Implementation Launchpad at the UW-Madison Institute for Clinical and Translational Research. This is the Dissemination Research and Implementation Science Seminar, also known as DRISS, which is a monthly lunchtime seminar to learn about the growing science of dissemination and implementation research and practice. This seminar is open to all and is part of the Implementation Science and Community Outcomes Certificate, which addresses the gap between basic research discoveries and their application in clinical and public health practice. Today's speaker is Dr. Andrew Quanbeck. Andrew is an associate professor in the University of Wisconsin's Department of Family Medicine and Community Health and is an honorary associate in the University of Wisconsin's Department of Industrial and Systems Engineering. Dr. Quanbeck heads the Implementation Science and Engineering Lab at UW-Madison. His research draws upon concepts from systems engineering to develop innovative approaches to implementing evidence-based practices. Dr. Quanbeck is currently the Principal Investigator on 4 NIH-funded R01 grants that use innovative systems engineering approaches to promote the implementation of evidence-based interventions for the prevention and treatment of substance use disorders in healthcare and community settings. Dr. Quanbeck is a standing member of NIH's Science of Implementation in Health and Healthcare Studies section, chair of the Osher Center for Integrative Medicine's Collaborative Research Committee, and a member of the editorial board of the journal Implementation Research and Practice. We are so excited to have him here presenting today. At this time, I will turn it over to Dr. Quanbeck. If you have a question or comment, please use the raise hand feature until our panelists will call on you. You are also welcome to use the chat feature to put any questions or comments you have throughout the talk that we will get to at the end. Thank you very much. And now, Dr. Quanbeck, please take it away.
Okay, well, thank you for the introduction and the invitation to present some of my research today. So working on a number of different projects and going to present some of the main findings from one of our first studies that was R01 level studies that was funded by the National Institute on Alcoholism and Alcohol Abuse. Let's see. My slides aren't advancing for some reason. Oh, there we go. All right, so I'm going to talk again a couple of grants focusing primarily on this first grant that was funded by NIAAA. Get into a little bit of research that we're just getting started. Another NIAAA grant that was just funded, and then also want to acknowledge the Department of Family Medicine Community Health Small Grant Program, which really was instrumental in helping us get our second grant listed here. Also want to acknowledge my co-authors and collaborators, Xiang Li, Chung Ji, Mingwan Chi, Linda S. Park, and Alice Palvermacher. I do have some financial disclosures to make. I have a shareholder interest in Chess Health, a small business that markets digital health applications to the addiction treatment field. I also provide consulting on digital health implementation through the nonprofit NIATEX Foundation. So we're going to talk about digital health for alcohol use disorders. And I have sort of a long trajectory of working in this area. I don't think I probably need to stress that alcohol use disorder is a prevalent issue in the U.S., especially in Wisconsin. We have, by a lot of stats, the highest rates of heavy and binge drinking anywhere in the country, which leads to all sorts of health, mental health, physical health, and societal harms. So it's an important problem to address, and it's only gotten worse since the COVID pandemic. So we know that it's a very prevalent issue, but the treatment for alcohol use disorders is very is kind of segmented away from the primary healthcare system. Very few people get treatment for alcohol use disorder. And we've been working, I came from the College of Engineering before moving to the medical school, and our research center has developed lots of technical interventions, technological interventions for chronic disease management. And the premise early on was that digital health could be helpful for alcohol use disorder treatment. So we really, Dave Gustafson, who's the director of CHESS, developed an early system for continuing care of patients coming out of residential treatment for severe alcohol use disorder, and showed in a randomized controlled trial, 349 patients, a significant reduction in heavy drinking days using HS. So this was one of the first digital health interventions shown to be effective in a randomized clinical trial, published in May 2014 in JAMA Psychiatry. And so we've, a very promising evidence-based technology. And I've been interested in future applications and implementation of this system to reach as many people as possible that could benefit from it. So the study that I'm going to talk about was looking at the possibility of integrating a version of the CHESS app into UW Health. I'm sure everyone, most of us are affiliated with UW Health, so you're familiar with the system. It has more than 700,000 patients each year, serving the Madison and Dane County community. The one thing about UW Health is that as a primary healthcare system, it doesn't really have provisions in place for substance use treatment. So that's typically handled, in a specialty system. So introducing this technology is sort of a new ground. And what role could technology play in treating alcohol use disorder within a primary healthcare system? So I talked about alcohol use a little bit. This is just kind of shows at a population level, the patterns of alcohol use. You see that about half of the population abstains, around 70% are low risk drinkers, but around 30% of the population, and even more in Wisconsin, would qualify as being sort of problem or at-risk drinkers, or all the way to alcohol use disorder. And so some level of intervention is recommended for people in that category. And that's a lot of people in a state of 7 million people, or a population of 700,000 patients. You're talking about a significant proportion of the population. But we don't have a lot of effective interventions for the population kind of in the upper middle part of this pyramid. The people who get treatment tend to be at the very sort of tippy top of this, and it's really a very small percentage. I think around 3% of people with alcohol use disorder get treated at all. So there's a lot of unmet needs in the community. So we came in, the idea was to try to introduce HS into the UW Health environment. We use the EPIS framework, which will be familiar to many of the listeners, I think. Exploration, preparation, implementation, and sustainment. So what we did, we came in, we had this NIAAA grant funded. We took the first year to take time to talk to stakeholders within UW Health, clinicians, behavioral health specialists, primary care physicians, health system leaders, people in the technology departments, and showed them we have this app. We want to try to introduce it. What kind of adaptations would we have to make to our intervention and implementation strategy to make this work and make it feasible to implement in this environment. So we did preparation, barriers and facilitators of implementation assessment, developed implementation strategies, and then really implementation is what I'm going to go over, the clinical trial results that we've just completed. And we're now at the phase where we're looking to, we have this paper under review currently. It's not published yet, but there will be, I think, some implications for sustainment, whether this should be sustained and whether, if it should be, whether and how to do that. So again, we wrote a grant. We put a year into the timeline for this exploration phase, and we learned a lot of things that we thought we were going to do. It ended up not being exactly what we did. We thought that it would be really important to integrate data from HS into patients' electronic health records, so that clinicians could see what patients are doing and monitor use. We found out from talking both to stakeholders at UW Health and to potential patients and users of the system that no one really wanted data on alcohol use in the electronic health record. Patients, because of the issues of stigma associated with alcohol use, clinicians, primary care physicians are very overburdened, and having one more data point that they'd be responsible for monitoring is not something that is to be taken lightly. There are also structural, institutional barriers that made that very difficult, and so we ended up not integrating data from the app into electronic medical records. We thought at first that this would be sort of managed and led by primary care physicians as the implementation agents, recommending the app and getting people on board and monitoring use. We learned more about the health system and found a better fit, I think, by utilizing health coaches or RNs working at the Center for Wellness within UW Health, who are really well positioned to do the type of health coaching that is required to use a system like this. We thought the original CHESS system was entirely focused on abstinence. And, when we look at the large swath of the population, if you're looking at 30%, might not be interested in abstinence, but I think everyone can agree that drinking less is a goal worth pursuing. So we went to more of a harm reduction model, that it's okay to having a drink is not the end of the world, but sort of positive framing around alcohol use reduction. We had a recovery-based model originally with HS. In working with the Center for Wellness, we learned about the whole health model, which was developed at UW-Madison and informs the basis of health coaching at the Center for Wellness. It's also widely used in the Veterans Administration, and really fits well with what we were trying to accomplish. And we thought we would start with a clinic-based approach. We were going to work with just 2 primary care clinics. We realized that we'd need to cast a wider net, and so we recruited it more at the health system level in a lot of different venues within UW Health and in the community as well, so that participants in the trial just had to be within the catchment area of UW Health, but weren't recruited from UW Health primary care clinics, or that was just a component, but not the only source of recruitment. So the original HS system is based on self-determination theory, which posits that people have 3 basic needs for autonomy, competence, and relatedness. And if those psychological needs can be satisfied, that can lead to better health. There's a pretty good correlation between self-determination theory and the whole health model. The sort of key phrase related to the whole health model is it changes the conversation between clinicians and patients from what's the matter with me to what matters to me. Why do I want my health? And how can I work together with a clinical team to set goals that will help achieve the important life goals that patients have. So it's sort of a holistic model with different components working the body, surroundings, personal development, food and drink, I won't go into all of them, but that formed the basis of the app that we created. So HS we adapted into an app called Tula. Tula is a Sanskrit word that means balance, and I'll just show you kind of what the app looks like from the patient's perspective. It has a couple of features worth mentioning. The tracker allows people to track their alcohol use on a weekly basis, and it sort of acts like a Fitbit for tracking steps, but it's more for alcohol use. We have communication modules that would allow individuals to communicate with the research team, as well as health coaches and peer mentors if they had availability of those resources. And then just a lot of evidence-based information and exercises and tools that people could use around like guided meditation and things like that. So in terms of the study design, it was really motivated in part by reading this paper, which came out in 2019 in the Journal of Medical Internet Research. It lays out the different types of support models that are being used to support digital health integration into health systems. And this isn't happening, very, very frequently at this point. So there's a lot to learn. If you look at the left side of the spectrum, it's just traditional care, human delivered interventions, where there's no role for technology, just kind of good old-fashioned healthcare. Adjunctive, so they call it behavioral intervention technologies here. So an adjunctive bit, the health intervention is delivered by a provider with support from the technology. And a guided bit is the intervention is delivered by the technology support from a provider, all the way over to a fully automated bit where the intervention is delivered by the technology and there's no role for the provider. So the categories in the middle are a little bit blurry, but I think fully automated bits we can all sort of identify with, because it's modeled after health apps that you could just download from the App Store or the Google Play Store and use on your own, and your clinical team would have no knowledge or involvement in your use of the app. So the study design that we came up with was designed to understand how varying levels of human support can affect the way in which an mHealth system like HS or Tula works within a health system. So we designed 3 different support models. Basically, we called it a self-monitored model where people just use the app on their own. We had a peer support model where we worked with the community-based organization to provide support from peers with lived experience with substance use. And then we had a clinical support model, which provided one-on-one health coaching through health coaches from UW Health. So you can sort of see that there's increasing levels of implementation complexity involved with layering on more intervention and implementation agents in the form of peer mentors and health coaches. The control strategy or the control model is basically just using the app on your own. So this was a hybrid type 1 effectiveness implementation study. So we are, and we're doing cost effectiveness analysis to kind of try to tease out what the optimal level of human touch would be required to support use of mHealth in a health system like UW Health. Our hypothesis is that increasing levels of human touch will increase the effectiveness of the app, and potentially allowing for us to pinpoint what are the most cost-effective trade-offs in terms of like what type of support should be provided for individuals to maximize effectiveness while keeping keeping track of costs and balancing that with effectiveness. So just a little more detail on the 3 study groups. So this was a patient-level randomized clinical trial. Individuals would be randomized to one of these 3 groups. So they would either get the self-monitoring group, where they just use Tula on their own, the peer-supported group, where people had access to a peer support specialist who would sort of introduce, welcome people as they came onto the study, and then they could participate in discussion forums that were moderated by the peer support specialists. And then a high-touch clinically integrated group, where Tula use is supported by a health coach. In the clinically integrated group, we sort of used a health coaching model so that people would get 3 monthly one-on-one phone calls lasting 30 minutes that would, kind of help the health coach work through and set goal setting and, showing people features of the app and helping them use the app. People also had access to discussion forum in the clinically integrated group, and there was health coaches could sort of see how patients were using the system and what levels of alcohol use they were engaged in. So in terms of patient inclusion criteria, I won't go through all of this. I think the important thing is that a couple of important things: 21 and older, had to have a smartphone. We didn't give away phones for this study. Didn't seem like that would be a practical thing to do, especially during COVID. People had to live within the healthcare UW Health's catchment area. So we verified that by using IP addresses and, just made sure that we didn't have people from outside of Dane County or the surrounding area participating. And then we tried to pinpoint a population where is kind of going back to that pyramid concept. We didn't have anyone who abstained from drinking. Obviously wouldn't make sense. And we didn't want people who had, no problem with alcohol. So we kind of set it to problem drinking up to mild to moderate alcohol use disorder. There's an 11-question questionnaire, and if you answer yes to like 6 or more, it would signal potentially severe alcohol use disorder. And we didn't think that people with severe alcohol use disorder would be appropriate for, this kind of harm reduction and prevention oriented app that we ended up developing. So people who had like no problem with alcohol weren't eligible, and people who had severe alcohol use disorder were also not eligible. So here's the consort diagram. We assessed or screened about 2,300 individuals. Roughly half we screened, or let's see here, roughly half were eligible. And then of those eligible, we ended up randomizing 558. Our recruitment goal was 546. So we met and exceeded our recruitment goal. This period between the onboarding and randomization was kind of a run-in period where people had to schedule a phone call with a research coordinator and do a baseline survey so that we would have baseline data for all randomized participants. So if people didn't schedule the phone call or didn't show up, and we also had to do that because we needed to verify that we were talking to a real person and not someone just trying to collect incentives via this study. So that process kind of got us down to 558 who were randomized and then allocated equally between the 3 groups. And you can see the follow-up rates for quarterly surveys that we did for outcomes assessment. A couple of things to note about this, and it'll be a theme going forward. Overall, our rates of follow-up were high for digital health studies. Digital health studies are sort of known for being having poor follow-up. If you average across all of the follow-up points, we ended up at like, I think 78% follow-up, which I looked at a systematic review of digital health studies, puts us, definitely like in the top quartile in terms of follow-up rates for digital health randomized trials. So our follow-up was good, and that was a strength of the study. The one thing you will notice is that follow-up rates dropped off pretty significantly in the clinically integrated or the health coaching group. So that at 12 months, where we're at 75% follow-up for self-monitoring, we're only at 55% for the health coaching group. So I'm gonna talk a little bit more about that. But we noticed that early on, and we worked really hard to try to follow up in all of the groups equally, but that's just kind of the way things turned out. So despite our best efforts. Primary outcomes were percent of risky drinking days in the last 7 days. So that's defined, I think, as 4 or more drinks in one sitting for a female, or 5 or more drinks for a male. And then we looked at quality of life via the PROMIS Global Physical Health and Mental Health Quality of Life scales. And we have a number of secondary outcomes that we'll be reporting separately, but we're just going to focus on the pre-specified primary outcomes at this stage. So I won't go into a ton of details, but our analysis plan was a general linear mixed model with repeated measures from month 3 to month 12. We controlled for baseline levels of outcomes at baseline, and then we stratified on sex and AUD severity, whether patients had mild or moderate AUD severity, to kind of balance that across the group. And I'm going to show you some graphs and charts. Just, I think it's always good to look at, run charts and things like that, and then our results of our statistical analysis. So this is the baseline table. Kind of a lot to digest there. I think the thing that I want to point out is that the population overall was about 2/3 female, primarily white, 91% white. The figures for the racial and ethnic background pretty closely match what UW Health has overall. The other thing I think that's notable is that it's a highly educated population. We know that Madison is one of the most highly educated regions in the country. I think it's second in the country. So you've got a lot of people with bachelor's and master's degrees and even PhDs. And more than half are married. A lot of people with severe alcohol use disorder are unmarried, I think, compared to this population. So that's, it's a very different population than what you would get in previous trials with people with severe alcohol use disorder. So that's just worth noting. So here's the just kind of a description, or give you the eyeball test of what happened over time between the three groups. So the upper left shows the percentage of risky drinking days. You see that it's around 40% in all 3 groups at baseline, and it came down pretty significantly over time in all 3 groups. But as you can see, the reductions in drinking tracked pretty closely with one another. In terms of quality of life, physical health, you can see that there's not really much going on there, pretty flat lines. Quality of life, mental health, we did see some differences, in particular between the self-monitoring group and the health coaching group. So some statistically significant difference in quality of life improvements among those getting health coaching. But this is important to look at as well. We also looked at adoption and use of the system. So, I mean, use pretty much always goes down with digital health apps. But you'll see that even at a year, more than 60% of people were using the app in the self-monitoring and peer-supported group, which is quite high by standards in the digital health field. But you'll see that, you know, it is quite a bit lower in the health coaching group, down around 50%. So, so there was some, you know, differential follow-up, differential rates of adoption as well for those assigned health coaching. So this is the primary statistical results, looking at the changes, you know, with time as the factor. You'll see that there's definitely, you know, very, very low p-values, so that the reductions over time was statistically significant across all three groups when it came to risky drinking days. However, if you look at the pairwise comparisons between the three groups, there were no significant differences in their effect on alcohol consumption. Also, no real effect on physical health, quality of life, no difference between the groups either. In terms of quality of life for mental health, you do see that the contrast between the clinically integrated group and the self-monitoring group is significant. That was the one pairwise difference that was significant. So it appears that, at least for people who stuck it out in the health coaching group, there were some improvements in mental health quality of life. That said, so we've submitted this paper for publication. We included a technical appendix with a sensitivity analysis. If we do a pattern mixture model where we sort of adjust for differential rates of follow-up, you know, it's a little bit, this is the intention to treat analysis with data treated as missing at random. You see an effect of health coaching on mental health quality of life, but some alternative models using different assumptions about missing data sort of washes away that effect. So it's really difficult. It's a little difficult to say whether that effect is something that we can count on, or if it's just more of a selection bias due to, you know, the people who stuck around were probably more likely to be doing well in the study than those who had dropped out. So there's some caution to interpreting that result, and we recognize that and are, you know, taking steps to look at alternative assumptions. So to summarize, again, the charts, as the chart showed, percentage of risky drinking days went from around 38% to 22% at 12 months. All the groups showed significant reductions in risky drinking days, but there's no difference in the groups. The clinically integrated group had improvements in mental health compared to self-monitoring. However, there's some, you know, have to be a little bit careful interpreting that. There was some, I didn't mention, there was some improvement in mental health in the peer-supported group between month 3 to month 6. We didn't find any effect on physical well-being. So some of the limitations. This was, you know, a very pragmatic trial. You know, we were, you know, talking to stakeholders. We had to make sure that this was going to be something feasible to implement within the system. That meant that there's no pure control group. You know, we had a control implementation strategy. To do a pure control group in an effectiveness trial, you know, requires like a sham device that basically doesn't do anything, and that didn't seem practical to do. So, you know, we have the changes that we saw over time could be explained by other factors, you know, just participating in research or temporal trends. Although I think there's a couple of mitigating factors that help kind of strengthen the argument that there was something there. Number one, drinking rates did go up significantly during the pandemic. So it's not like people everywhere were reducing alcohol use during this time period. And, you know, we had the assessments were done for alcohol alcohol consumption as well as physical health. We didn't see any change in physical health, quality of life, even though it was the same survey that was used to collect those measures. So it seemed like, we have some basis for saying this did affect alcohol use, but it didn't affect physical health. Again, self-reported alcohol use was really the only option we had through this app. We planned on doing in-person coaching, or at least having an option for in-person coaching. We had to do all that virtually due to COVID, unsurprisingly. And then, we recognize that this is largely a, middle-aged, highly educated, white female study population. And that's consistent with a lot of research on sort of integrative medicine interventions like the one that we tested. That seems to be the group that is most willing to use systems like this. So the results might not generalize to other populations. So again, we have lots of other outcomes assessment that we're doing. We're doing qualitative interviews with the health coaches to sort of understand the experience. We're also doing interviews with participants, which I didn't list here, but we're doing participants in the health coaching intervention, as well as the other groups, just to kind of get the patient perspective. We're going to do economic analysis to try to determine, what is it worth to reduce alcohol use on this to this level. There's not a lot of guidance in the literature on those questions. And then mediation analysis to try to see if we can parse out some of the effects that we saw between the groups in terms of some of the constructs of self-determination theory, because we have measurement variables in place that we can look at those things. So in terms of implications, there's really not a lot out there for people, preventive interventions for alcohol use disorder to prevent things from progressing from mild to moderate to severe. The standard within UW Health and most health systems is screening, brief intervention, and referral to treatment. But there's just a lot of issues with implementation of that system that I think are, it's been around since the 90s and still not very widely or well implemented. The economic analysis is really going to try to, answer some of the questions like, well, what is it worth to reduce drinking by 16 percentage points or 41%? We're talking about like roughly one less heavy drinking day per person per week. And, what is that worth? It's hard to say. Economic analysis is how we're going to tackle that question. We think that based on the results, it might make sense to offer the self-guided version of the app for everyone, since it did have effects on alcohol use, and potentially to provide options for health coaching and peer support due to potential improvements in mental health. There's a lot of literature on the importance of patient choice and intervention selection. I think this is something that we saw, that health coaching might not be the type of intervention that people want if they're just trying to reduce alcohol use. I think there might be a preference for privacy and doing it on your own. But some people, really did well with health coaching and valued it. So I think there's the role of patient choice is something that needs to be thought through a bit more. So I'm just going to quickly touch on where we're heading next. So the other thing that's happening, and if you'll see this in the news, that alcohol-associated liver disease is becoming more and more prevalent. People at younger ages, especially women, are experiencing liver damage due to alcohol use that is requiring, and it's a deadly condition that can require a liver transplant. And the only abstinence is the only intervention that can reduce morbidity and mortality for people who have gotten to the stage of alcohol-associated liver disease. But really, there's a gap in patient care, because the standard of care for the medical system is if people have alcohol-associated liver disease, you treat the medical condition, but as far as alcohol use, the advice is like go to AA and stop drinking. And we know that that doesn't happen very often. So we're looking at ways to try to, more proactively treat the issue. So, there are evidence-based treatments out there. It's exciting that at UW-Madison and the University of Michigan, where we're doing this study, there are integrated medically managed AUD treatment clinics led by my colleagues, Dr. Randy Brown and Dr. Jessica Mellinger, where we're really starting to kind of take this problem head on within the medical system and, providing pharmacotherapy. And then we're studying how we can support this model with digital interventions like HS. So in this new study that we're just getting started, we haven't started recruiting patients yet, but we're going to be testing HS in a population of patients with alcohol-associated liver disease. This again is going to be a type 1 hybrid effectiveness implementation trial with patient level randomizations. We're going to recruit 298 patients from UW Health and the University of Michigan. And it'll be a 1-to-1 intervention versus control RCT. And we're hopeful that through this study we can, really help to set a new standard of care for ALD within healthcare settings, because alcohol is the cause of this liver damage, and we want to take the treatment of alcohol use sort of head on within the healthcare system. And it's encouraging to see that Wisconsin and Michigan are really in the vanguard in terms of treating addiction and alcohol use disorder as medical conditions that need to be treated medically. So that's it. Haven't been monitoring the chat, but we have about 18 minutes left for your questions, comments, and feedback. I'm especially interested in if anyone has any sort of thoughts about, what are the next steps? What are the implications? Should this be sustained? How should it be sustained? And I'll leave it at that. So thank you for your time.
Thank you, Dr. Quanbeck. I'm going to start asking some questions off a chat. Depending on if we need a little bit more clarity regarding your question, we might see if either you can put it in chat or we can give you the opportunity to use your voice to share it. So to start with, we have a question that's saying that part of the issue of monitoring of an important health domain is undesirable or prohibitive. This person would be interested in hearing at the end how to manage or consider the challenges of recording these important pieces of health data.
Yeah, I'm just reading the question real quick here. So important pieces of health data, I assume that's alcohol consumption, basically. Yeah, or maybe I don't know if Shannon wants to clarify. I'm not totally sure when it says that's not surprising, because I don't know I wasn't monitoring the chat, so I'm not sure exactly at what point that.
Shannon, if you want to.
Sure. Thanks, Dr. Quanbeck. I really appreciate your presentation this morning. And I think you raised such an important point in the beginning about the institutional, systematic way with which important health indicators like alcohol use is maybe inconsistently monitored, or either folks may not be willing to have that information monitored, or providers are too busy to monitor those kinds of data. And those seem really important to someone's health status. And also, it's one of probably 100 different indicators that would be useful for us to be able to know, understand, track, evaluate within an EHR. So the question is really, how do we consider then that challenge of not being able to record some really critical, important information? And What does it say then about our health data if it's incomplete, in part related to these systematic difficulties? Thank you so much.
Yeah. Well, I mean, you're raising, I think they're, it's a real conundrum. And I think this is, the experience probably a lot of us have had, because the way that, there is sort of a mechanism in place for recording alcohol use by usually health, annual physicals will do screening for alcohol use. But often, it's almost like a don't ask, don't tell kind of thing. Like I think that physicians aren't really often are like, well, I don't know what if someone says that I'm, drinking 50 drinks a week, or what are you supposed to do then? There's no resources within the health system to do anything about it. And I think that patients are worried that that information in their health record is going to be there and cause problems for them in the future. I don't know that so I don't have an answer for it. I mean, it was something that, and as I mentioned too, there's concerns about, knowing about something like that in the health record. And it's like, well, if you didn't do anything about it, that was something that I think, clinicians were justifiably concerned about. So what we did in this, what we're finding is that in our qualitative interviews, people really seem, the tracking of alcohol use seems to be an effective type of intervention by itself. It's the issue is then like sharing the data. But I think that there's value in individuals tracking on their own. A lot of us, I think the Fitbit analogy of trying to get your steps or whatever can be motivating, trying to see like, oh, look at I have this good pattern, this good trend, and I haven't drank or been drinking less or drinking less often. But the question about how to integrate it into healthcare, I think is still tricky. And so I wish I had more of an answer for it. I could, there's another digital health company named Paratherapeutics that had more of a fully integrated model that was going to be integrated with electronic health records, sort of physician guided, and their company failed on a pretty spectacular scale. And it's hard to say exactly why that is, but there were some issues, and I don't know to what extent privacy issues and stigma played a role in that, but I think it probably factored in to some extent. So I don't know. It's a tricky one. But
thank you for your response.
We dealt with it in our study. Yeah, thanks for the question.
No, thank you.
Thank you. The next several questions came from Dr. Liu. So Dr. Liu, if you would like to come off mute and share, you are welcome to do that. Otherwise, I can read through the questions. Great. Then I will read through the questions. So Dr. Quanbeck, can you share a little bit about why do you think participation dropped more in the clinically integrated arm?
Yeah, I mean, we're doing some qualitative analysis of this. My feeling is that it's a very it's a different experience using an app on your own or using an app in a sort of an anonymous peer discussion group where you have, you're just using like screen names and it's all done virtually. Health coaching it has a couple of things. Number one, you sort of break into more of a, if you're talking to a person on the phone, even though I think they use like screen names as part of the health coaching, it's a much more intimate experience. And I think that people, are probably more willing to try something out on their own or try something out that's anonymous, as opposed to like health coaching is a much more personal intervention. It's also more, it requires synchronous, it's a synchronous communication channel. You're getting on the phone, which means you got to set a time, schedule a time. Both people have to pick up, and so that makes no showing kind of more likely. But we even heard sort of anecdotally, when this was not a blinded study for pragmatic reasons. We sort of heard people like when a few people got assigned to the health coaching group, they were like, oh man, I wanted to just do this on my own. I don't want to have to talk to somebody. I think for sort of this pre-contemplative population who's, like, well, I don't think I really have a problem that needs to be dealt with by a one-on-one therapist. So I think it's like treatment overmatching is maybe one of the technical terms for that, where the level of intervention is maybe a little bit, at least from the participant's perspective, is maybe more than what they're looking for to deal with their issue. That's my speculation. But hopefully we'll learn more about that from participants themselves when we get qualitative results. I mean, again, we're only going to be talking to a few people, so we can't say for sure, but that's kind of my hunch.
Thank you for providing a little bit more information about why you think that is the case. And we look forward to hearing if the results of those qualitative interviews support or give other reasons. The next comment came from Aaron Hicks. And again, if you're able to share a little bit more, that'd be super helpful, because I don't exactly remember which slide Dr. Quanbeck was on. So if you are able to, please let me know. If not, I will do my best. And while we do try to figure that out with Aaron, there was another question here that just people are curious about your proposed control for the new ALD study. Can you share a little bit more about what the control might be, or maybe alternatives?
Yeah. So it's I mean, there's similarities, but it's quite a different study, because this is a severe this is closer to like the original HS studies in a certain sense. You could argue that this is almost the most severely affected population you can have. So there's a lot of, this is pretty much, mostly an effectiveness trial. So we have there's a chess, a group is going to get chess, which is going to include all of the components, monitoring, peer mentorship, communication with the research team and the clinical team. Whereas the control group is only going to be answering, they're just going to be tracking alcohol use, which is still, still sort of an intervention, but there's almost no way to avoid that. But so they're going to get like a REDCap app. Instead of downloading HS and all of the features that it has, they're just going to get a REDCap app that's going to push surveys at them to provide outcomes data, and that's basically it. And probably some minimal information on just minimal, like publicly available information on alcohol use disorder that people could access. That's how we're setting that one up. But we did think it was really important. That's a very clinical study. The population is very complex. So it's a little bit less about implementation, although I think there are major implications for implementation if we see effectiveness of that system for the future role of overall treatment of alcohol use disorders within medical care settings. It seems certainly makes sense to me that people with alcohol-associated liver disease should have integrated treatment for alcohol use disorder. If any population within the health system should have it, I think that they should. So So that's where I think, it could set a new standard for care for this population.
Thank you, Andrew, for sharing more about that potential that control that you are going to do for that piece of the study. Erin, are you able to come off of mute? Otherwise, I apologize, but I will need a little more detail. We probably have time for one more question, if anyone has any. And we just put the link to the feedback survey into the chat, and we'd really appreciate if everyone could fill that out as soon as they're able. If there are no more questions, then I will say thank you to Dr. Quanbeck for your time and expertise today. We really enjoyed learning about your work. And a thank you to all of our participants for attending the DRISS seminar. We included a link to the short DRISS evaluation in the chat box and would really appreciate and be grateful if you could share your feedback with us by completing it. We will also send out a follow-up email that includes the evaluation link and information about our YouTube channel, which hosts the recordings of these seminars. Thank you, everyone, and we will look forward to seeing you at our next DRISS seminar, which will be on Friday, May 10th at noon. Have a great rest of your day. Thank you.
Thank you. Have a good one.